silicon, also called silicon dioxide. It's a well-known occupational respiratory hazard that continues to cause disease today. The hazard comes from respirable-sized crystalline silica, of which quartz is the most common form. Silica is found in rock and concrete and masonry and silica sand. So workers can be exposed anytime they disrupt a solid silica-containing material. That might be by drilling through rock or cutting concrete. They can also encounter silica during sandblasting, demolition work, and mining. So these are really well-known, long-standing risks. And the issue, really, the problem starts with respirable crystalline silica particles, which are very small. This image gives you a sense of how they compare to a grain of salt. And those small particles can reach the deep lung, the alveoli, where they can cause inflammation and scarring of lung tissue. And that's the disease that we know as silicosis. Over time, this reaction to the silica can lead to respiratory failure and eventually death. So I told you about some well-known risks or industries where silicosis is known to happen. The new risk is this material called engineered stone. And so we'll do a poll here. I'll pose this question. What features of engineered stone contribute to its toxicity? Is it the high silica content, the resin component, the small particle size, the metal component, both the silica content and the small particle size, or all of these features? So I think the poll is completed here. And just over half of you chose all of the above, with a large proportion also choosing A and C. And I would argue that it's all of the above, that these multiple features of this material are contributing to its toxicity. And we'll get into that a little bit more as we go. So if you take a look at this beautiful kitchen, I suspect that some of you have looked for a new home or considered renovating your kitchen in the last 5 to 10 years. And if you did, you probably heard about quartz countertops during that process. Quartz countertops are known more formally as engineered stone or artificial stone countertops. And they are a composite material that's made of crushed quartz, which is bound together with a resin, a polyester material, and pigments that are used for the color and pattern. And this material has really been gaining in popularity due to factors like its durability and stain resistance. This graph shows that since 2007, demand for engineered stone in the US has increased dramatically. And it's now the most popular material in our country for countertops. And I think that's true really in many countries. The global market is billions of dollars, and the forecast is that global production will increase by 6% per year in the coming years. So as I described earlier, silicosis is a severe and incurable lung disease, and it's caused by inhaling silica dust particles. And this engineered stone material used for kitchen countertops, bathroom countertops, it contains typically more than 90% silica. And so that means that the workers who cut and grind this material, who are called stone fabricators, can be exposed to very hazardous levels of silica dust. And I think this picture kind of captures just how dusty it can be in these shops. This slide shows you how engineered stone's silica content compares to that of the natural stones that it's often meant to mimic or replace. It has much higher silica content than, for instance, marble or granite. But it also has resins, typically a polyester resin that's holding all of that ground silica together. And when you cut through that to to fabricate the countertop, volatile organic chemicals, things like styrene are released that we know are hazardous to the lungs. The pigments that are used often contain metals that we know are toxic to the lung. And then another important feature is the small particle size. So in the lab, when these materials have been examined and compared, the engineered stone tends to generate much smaller particles in the ultrafine range compared to what the natural stone generates. So those really fine particles likely contribute to its toxicity. And one of our colleagues in Australia who has looked at the physicochemical properties of this material calls this combination a cocktail of hazards. Let's talk a little bit about the global epidemic. Another question here. When were the first cases of silicosis associated with engineered stone reported in the medical literature? Was it 2002, 2007, 2010, or 2015? The first reported case that I'm aware of, there's a series of 3 cases that were reported from Spain in 2010. And I think the takeaway here is that this isn't a brand new problem. It's been going on now for 15 or more years, and yet continues. We'll get to a little bit more of the epidemiology in a moment. A little bit of background on the agency that I work for. So the occupational health branch is a multidisciplinary unit within our state health department. And our mission is to promote safe and healthy workplaces for all Californians. And we do have authority to collect records and data related to workplace health and to conduct worksite investigations. We don't enforce workplace regulations, but we work closely with Cal OSHA, which is the state regulator, to provide scientific support and to educate employers and workers about requirements. And so with the increasing demand for engineered stone worldwide came reports of silicosis in countertop fabrication workers. And as I said, the first that I know of it was from Spain in 2010, which was followed by a case series from Israel in 2012, in which they found cases in their lung transplant service. And that was followed by reports from many other countries. The first case in the United States was reported in 2015 from the state of Texas. And when we heard about that, the cases that were happening internationally, but then the fact that there was a case in the US, it made us wonder if California's workers could be at risk. And so we began looking for cases in California, and a very astute epidemiologist in our group found the first case in 2019 by reviewing hospital discharge records that we have access to as a public health agency. So she identified a 37-year-old man who'd been hospitalized with silicosis in 2017. He had worked at a countertop fabrication shop for almost a decade. He was diagnosed with silicosis in 2013 and then experienced worsening symptoms and lung function over the subsequent few years. And in 2018 was referred for a lung transplant, but was deemed ineligible and died later that year at the age of 38 of silicosis. And so we conducted a workplace investigation with Cal OSHA, the regulator, that identified 2 additional cases that had occurred among coworkers, including another fatality. So this was 3 cases in one shop. They were all young Hispanic immigrants in their 30s at diagnosis. And so then Cal OSHA had the employer conduct chest X-ray screening of the remaining workforce. and found an additional 5 cases for a silicosis prevalence among the current workforce of 12%. And the median age of cases detected by screening was just 37. And so after that kind of index case and experience in that workplace, we began expanding our surveillance efforts to track silicosis across the state. We continue to use that hospital data, both discharge and emergency room data that we have access to. There has also been some voluntary provider reporting as we've increased awareness of the problem. Healthcare providers have started to report to us. We have really piloted a new electronic case reporting system for that we refer to as ECR. That allows hospitals' electronic medical record to automatically report a case to public health if certain triggers are met. And we found quite a few cases that way. We've advocated for and succeeded in adding silicosis to the state's list of reportable conditions as of this July. Meaning that at this time and moving forward, it is actually the law in California that cases of silicosis have to be reported to public health. And that's an unusual thing to be on the list of reportable diseases. Typically, it's a lot of infectious diseases, things like anthrax and botulism. So getting silicosis on that list really reflected the concern that the state has about this problem. We use the NIOSH surveillance case definition, which means that it requires occupational exposure to silica and either radiologic or pathologic findings of silicosis. We've also been doing some surveillance to try to understand the industry in the state, to enumerate fabrication shops. We've been using a business, commercially available business database, web searches, and outreach in partnership with local health departments to really understand where are these shops and how many are there. We have found through our surveillance that a lot of the disease that's being reported is advanced disease. So you can see here on the left is what we call simple silicosis. So if you're not used to looking at a chest CT, imagine the patient is lying on his back, his legs are coming out of the screen, and this is a cross section through the chest. And on the left, you kind of see a starry sky type of picture, all these little white dots that shouldn't be there in the lungs. And that's called simple silicosis. Those are the small nodules of inflammation and scarring of the lung. Complicated silicosis, it's also sometimes referred to as progressive massive fibrosis. That's when those little nodules come together, coalesce into masses that are at least a centimeter in diameter. And so you can appreciate here these white scars that really would impact lung function and result in symptoms. And when we looked in detail at the first 50 or so cases that we had identified, we found that more than a third were this complicated advanced disease. Earlier this year, we developed and posted this dashboard that we call the Engineered Stone Silicosis Surveillance Dashboard, and we're updating it weekly. It was just updated yesterday. I'm sorry I didn't change the slide. We're up to 411 cases, so we're seeing more cases on a weekly basis. We added another death as well, 23. And you can see that the median age of diagnosis among these 400 plus cases is 46, and the median age of death is 47. Those ages are important because silicosis typically, when we see it in other industries, it's a disease kind of that happens at the end of someone's career after many decades of exposure. So to see a median age in the 40s, meaning that there are cases as young as, I think the youngest we have is 27, and there are many in their 30s and 40s. This really is rapidly progressive disease for a scarring lung disease. You can see that nearly all of the cases have occurred in men, and most also in Latinos. The lower left here shows the last known transplant status, and you can see that 47, so more than 10% have undergone lung transplants to date. Others have been referred, and some have been referred but found ineligible. So we expect the number of transplants to increase as more cases are identified. In the middle here, we have the year that we confirmed. We started in 2019, and you can see that it's really been increasing. We've already exceeded the number in prior years, and we haven't even completed 2025 yet. Year of diagnosis isn't always available, but when it is, we include it, and you can see it goes back. The first one that we are aware of was diagnosed in 2006. So this problem's been around for a while in California, but obviously really took off after about 2020 or so. And that likely reflects the pattern of use of the material in the state. There is some lag time between when the material has been introduced and the number of years it takes of exposure to develop disease and then be diagnosed and reported to the state. We also have an interactive map that people can use to see where in the state cases are clustered, and it's really around the population center. So Los Angeles County, which is our largest county with 10 million people, has the most cases. Other counties in Southern California, and then the counties around the San Francisco Bay Area are where the most cases are. And as alarming as these numbers are, we're worried that it's really the tip of an iceberg. We know that there are on the order of 800 or more shops in California from the work we've been doing. We've very roughly estimated that there are on the order of 100,000 workers in the US. And in California, we're not exactly sure how many people work in this industry, but a rough guesstimate would be to take 10% of the national total, since we represent about 10% of the country. So we're talking about thousands of workers in the state who do this kind of work. And when we apply the prevalence that we got from chest X-ray screening of 12%, or if we look to our colleagues in Australia who have been using more sensitive diagnostic tests like CAT scanning, CT scanning of the chest, and finding prevalences of in excess of 20%, we suspect that there are thousands more cases that have yet to be identified, both in California and nationally. So let's talk a little bit about exposure. I have another question here. True, false, overexposure to silica during countertop fabrication using engineered stone is a problem only in small shops. Great, so we had a lot of agreement here that this was false, and that's right. You will hear people talk about it being a problem in small shops, that there are just a few bad actors. But what we're finding is that this is an exposure that's very hard to control, no matter the size of the shop or the resources available. Well, as it happens, federal OSHA introduced a new silica rule in 2016, and that was adopted by CalOSHA, our state program here in California. This new rule lowered the exposure limit for respirable crystalline silica several-fold to 50 micrograms per cubic meter, and it added an action level of 25 micrograms per cubic meter, after which certain steps have to be taken. The rule also introduced requirements for exposure monitoring, for using particular exposure controls, for training workers, and medical exam requirements, including chest X-ray, spirometry, a lung function test, and testing for tuberculosis on at baseline. Well, when Cal OSHA learned of the cases that we were finding in the state, they set up something called a special emphasis program. Typically, Cal OSHA is responding to complaints. That's where their authority kicks in. And they don't typically go and just make a surprise visit to a random shop that doesn't have a complaint associated with it. But a special emphasis program is a mechanism that allows them to identify an industry that they're concerned about and then basically inspect without a complaint. And so they set up a special emphasis program in 2019, and they ran that until the pandemic hit. And during that time, they opened 106 inspections and they performed air sampling at 47. And I'll just remind you that the permissible exposure limit is 50 micrograms per cubic meter, and the action level is 25 micrograms per cubic meter. And we were able to collaborate with Cal OSHA and review the inspection data. And this is what we found. Of the 47 companies with at least one exposure measurement, those companies are represented across the x-axis by these little ticks. And then the y-axis has the silica exposure. And those that are above the permissible exposure limit are in purple. Those that are between the action level and the PEL are in orange, and then those below the action level are in green. And so you'll see that some shops had multiple measurements. And the big takeaway here is that 24 or a little over half of the shops that were inspected, just kind of randomly chosen by Cal OSHA, had at least one exposure above that permissible exposure limit. And you can see that some of them were really wildly above, this one up here, maximum almost 700, but there were many in the well over 100, 200, 300 range. So these are really high exposures on the day that Cal OSHA came and sampled. During the special emphasis program, the inspectors from Cal OSHA administered a questionnaire that we had developed in partnership with them, and they conducted a total of 92 interviews, and we took a look at those results. In general, the workers were young with relatively short tenure in the industry. Many were Spanish speaking. They nearly all reported performing dust generating tasks, and a quarter said that they used dry methods, so they didn't use water to try to tamp down the dust. Most had not been informed of any air sampling happening at their workplace, and few had been fit tested for a respirator or offered a medical examination, although those things are required under the regulations. I want to point out that idea about size, shop size and exposure control. And I think the takeaway that I want to leave you with is that exposure control for this material is really challenging. And there's a study that was published last year from Australia in which they sampled 34 workers in 6 small shops in 2017. So this was really at the beginning of the recognition of the problem in Australia, before they had really taken steps to try to address the issue. So at that time, their permissible exposure limit was 100 micrograms per cubic meter, and they found that 85% of the workers exceeded that limit when they were conducting dry tasks, but 71% exceeded it when they were using water-fed tools, which we talk about, doing wet processes as the way to lower exposures. And yet the majority were still exceeding 100 micrograms per cubic meter. And then another Australian study that was published last year as well kind of makes a nice contrast. This second study looked at 123 workers in 27 shops after a 5-year campaign. So this is kind of at the end of 5 years of interventions. So they had educational efforts. They had regulatory efforts where they lowered their permissible exposure limit to 50 micrograms per meter. They did a lot of inspections and a lot of enforcement. And the result after all of that was that the geometric mean silica concentration was 34 micrograms per cubic meter with a 95th percentile of 174. And again, more than half of shops exceeded their new permissible exposure limit of 50. So while these two studies can't necessarily be directly compared, I think it's fair to say that exposures after the 5-year campaign were lower than they had been in 2017. But there was still a lot of overexposure happening despite all of their efforts. And we see something similar in the US, in Georgia. Um, uh, there's a group at Georgia Tech, a university that provides consultation for the federal OSHA. So they go in and offer. Sorry about that. There we go. They go in and offer shops consultations, so support when they're trying to comply with the regulations. It's non-enforcement. And what they found over the course of several years was that among 63 workers who were using wet methods, about half exceeded the 50 micrograms per cubic meter and 70% exceeded that action level. And they saw overexposures both in the small shops and large shops. Small they defined as being less than 25 employees, and large shops 25 or greater. So it's a really hard exposure to control when you are cutting through something that's almost pure silica and you have an extremely low exposure limit that you're trying to meet. It's very challenging. So let's talk now about prevention. Question 4, what type of respirator is now required in California for countertop fabricators using engineered stone? Is it disposable N95 filtering facepiece respirator, a half-face elastomeric respirator, a full-face elastomeric respirator, a full-face tight-fitting powered air purifying respirator or PAPR, or a supplied air respirator? Great. So the most popular answer here was the correct one, a full-face tight-fitting powered air purifying respirator, PAPR. And I'll go into that a little bit more. So as we were planning our response to this growing epidemic, we realized that there were challenges on many levels. These included at the level of the product, which is widely available, it's extremely popular, and it's toxic to fabricators, but not to consumers. And I want to be clear that I'm not trying to suggest that it would be a good thing if this were also toxic to the general public. But I think that you can imagine if this material in someone's kitchen was causing lung disease, that there would be a more concerted effort to address it than what we've seen when it's only affecting workers. In terms of the industry, it's a global industry. It's very decentralized. A lot of the fabrication shops are small, so they can be hard to reach. The workers are generally not unionized. They're often socioeconomically vulnerable, whether because of language, education, immigration status. So that makes them hard to reach. In addition, I've told you about over 400 cases that have been diagnosed in our state, and yet this is an unusual disease. It's still a rare disease, and most clinicians probably haven't diagnosed or treated silicosis. So clinicians are unfamiliar with the disease itself, and certainly with now that it's a reportable disease, that's not typical for a chronic lung disease to be reportable to public health. So there's that issue as well. And the public health side, our surveillance tools are limited. We don't have the resources to go out and just start screening people as they have done in Australia. So we're really relying on existing data that there can be long delays between the time that someone's hospitalized and we hear about it. And then also it's challenging to reach this population. Outreach can be difficult because they're so dispersed and in small shops and hard to reach. And then in terms of regulators, we do have a silica regulation, but it has the existing federal regulation that CalOSHA adopted in 2016 was seen as having loopholes. It's things that employers can take advantage of. It's difficult to enforce because it requires the inspector to do 8 hours of air sampling to prove that there's an overexposure. And then even when a violation is demonstrated, the citations that CalOSHA issues tend to be small and probably have limited impact on the conditions. And also there's no regulation of the sale of this toxic product. Virtually anyone can purchase it, whether or not they know how to safely use it. And so we found that we really, in order to prevent disease, we really needed to use a multidisciplinary approach. And that includes disease surveillance involving public health and clinicians, enforcement involving the regulatory agency, product stewardship, where we're relying on industry as well as government. Education and support has been really important, not only CalOSHA and the health department, but we have worked with local health departments, with our universities in the state to try to get the word out. The media has done, I think, a pretty good job of trying to raise awareness among consumers as well. So it's really taken a lot of players. One of the things that we've done at the health department is to initiate what we call the California Artificial Stone and Silicosis, or CAS project. And it's funded by NIOSH, the National Institute for Occupational Safety and Health, through a total worker health center that's based at the University of California, San Francisco, that's called the California Labor Lab. And this project has a couple of aims to educate employers and workers, to support early diagnosis, and to improve public health surveillance. So some of the things that we've done over the past few years is to develop educational materials for workers and employers. We have collaborated in particular with the LA County Department of Public Health and local community organizations to conduct outreach in LA, where a lot of the cases have occurred. We've developed resources for healthcare providers, including a fact sheet, a health alert advisory. We developed a continuing medical education course that's free and available online. And we've given grand rounds and other presentations to professional organizations like the California Medical Association. The CAS project has a study embedded in it, which is a collaboration with all of UCLA Medical Center, in which we're enrolling current countertop fabrication workers who live in LA County. We administer a questionnaire, and then they undergo a number of different screening tests so that we can compare the performance of the standard test, chest X-ray and spirometry, with enhanced tests, including a low-dose chest CT and full pulmonary function tests. And we're also collecting blood for blood biomarkers. And we've enrolled about 65 people to date. I mentioned this a little bit earlier. We've developed some new surveillance tools. We're using that Reportable Conditions Knowledge Management System, or RCKMS, to facilitate electronic case reporting, where the electronic health record essentially reports to us, so that we don't have to have a clinician taking time out of their busy day to figure out who do I report to, how do I get this where it needs to go, and where's the fax machine to send this report. So it's really taking advantage of electronic records and automated systems. Title 17 is the California Code section that includes reportable diseases and conditions. And as I mentioned, as of July, we've added silicosis, and we're expecting to hear about more cases because of that. Okay, so this slide shows the hierarchy of controls, which is likely familiar to a lot of you. It lists potential ways to control a workplace hazard from most effective to least effective. And the controls that have been used for silica exposure in this industry to date, there's really been a focus on controls that are lower on the hierarchy, engineering controls like wet methods and ventilation, administrative controls like restricting access to certain areas where exposures may be occurring. And then there's been a real emphasis on personal protective equipment, specifically respirators. I mentioned Cal OSHA's regulation. That federal regulation had some loopholes and some ways that some challenges to it. And so Cal OSHA actually put into place an emergency temporary standard in December of 2023. So they modified the existing regulation to ban dry cutting, to require a much higher level of respiratory protection, specifically that full face PAPR. And then they also incorporated the ability of the inspector to issue an order prohibiting use. So if the Cal OSHA inspector sees, for instance, dry cutting happening, he or she doesn't have to hang a pump and measure the exposures for 8 hours. This regulation says we know that dry cutting is an imminent hazard, and therefore that operation can be shut down. And they have done that on numerous occasions now. And so that really has facilitated enforcement. And just this past year, at the end of 2024, those emergency measures were incorporated into the permanent standard, which and they also added a few new features. Chest CT is now required for medical screening every 3 years for workers who use this material. And to my knowledge, that's the first occupational health regulation requiring CT in the US. And the other piece that really we're interested in receiving reports from all the medical screening, and they wrote that into the standards so that not only will cases of disease be reported to the health department, but anytime someone is screened, the results will be reported to us so that we can have a better sense of the denominator, how many people are being screened and what % are found to have silicosis. This slide shows you some preliminary results from the 2024 emergency temporary standard inspections. Cal OSHA did 85 inspections over the course of about a year. And you can see that most of them have been closed, a few are still ongoing. But the real takeaway here is that 95% were closed with violations. In other words, there's widespread non-compliance across this industry. And 26%, so 1 in 4 shops were issued an order prohibiting use. In other words, dry cutting or another imminent hazard was observed, and the shop was closed until that was remedied. So back to that hierarchy of controls, I think the experience that we're having in California, as well as experiences in other countries, really tells us that it's challenging to control this epidemic by focusing on those controls that are lower on the hierarchy. And so we should really be thinking about controls that are higher on this chart. And one of those is substitution. So engineered stone is not an essential item. People can survive with a kitchen countertop that's not made of this material. And so there's really an opportunity here, I think, to communicate to designers, architects, and their customers that it's possible to select products with lower or even no silica content. These include natural products like marble, granite, and wood, manufactured products like ceramic, porcelain, and concrete. And there are also new engineered stone products that are coming on the market, particularly driven by changes that have happened in Australia. And those products are reported to have much lower, if not no silica content. And I think, you know, they haven't necessarily been vetted for their health effects, but I think that given what we've seen with regards to the high silica artificial stone or engineered stone, I think these other products are likely to pose a lower risk. None of these are completely without risk, but I think they're likely to pose a lower risk than what's currently available. The final component of the hierarchy of controls is elimination. It's considered the most effective. Just remove the hazard, and Australia really has led the way here. They went through a very similar experience that we're having in California in terms of identifying the problem, changing their regulations, doing more enforcement, doing education, and they ended up concluding that the changes were not going to control this problem. And so they put together a national dust disease task force that looked at all of the data and recommended that the government ban engineered stone, which the government did as of last year. So companies are no longer allowed to manufacture, supply, process, or install engineered stone in Australia. So that brings me to this summary that silicosis from engineered stone is a large and growing problem. It impacts a young, primarily immigrant workforce. We think the burden of disease is likely underestimated and that prevention is really going to require a multifaceted approach. And I will end on this slide that acknowledges the many people, both at CDPH and at other institutions in California that have helped with this work. And that picture shows Dr. Jane Fazio and her patient, Gustavo Reyes, who I showed you at the beginning after his lung transplant. So I would be happy to take questions.
So, wow, thank you so much.